Hello Internet and welcome to MedVIP. Today we're going to be talking about normal kidney function. We're going to start with talking about normal kidney anatomy. So here you can actually see a gross picture of the kidney, and it's actually been bisected and cut in half across the calyx. Now what we see on the left is an actual picture of the cortex of the kidney, and just like every other structure in the body which has a cortex and a medulla, the word cortex stems from the Greek word for bark, and medulla stems from the Latin word for marrow, like the bone marrow. So the medulla is the center of the organ, and the cortex is the outside, or the bark, or surface of the organ. As you can see, the kidney is covered by a fibrous capsule, and it is a retroperitoneal organ. Now, if you really want to look at the internal anatomy of the kidney, you got to look at the cut edge, which is here on the right of this picture. So the first things that we notice is that it's a gross picture. It's not too informative. So why don't we put up a diagram of the kidney side by side so we can actually compare the two. Let's first talk about the kidney's vascular supply. As you can see, each kidney is fed by a renal artery. That renal artery comes off of the aorta. And eventually, each kidney drains out by a renal vein, which joins up with the IVC. Because in the abdomen, the aorta arches over to the left and travels to the left, and the IVC is on the right, we can expect a shorter left renal artery. So normally, the left renal vein travels in front of the aorta, but occasionally, about 10% of the time, you can actually get a retroaortic left renal vein. And this becomes a problem when you're trying to access the kidney for aneurysm repair. For those of you who are interested in surgery, that's going to be something you might be asked on the wards. Now that we've talked about the major input and outputs to each kidney, let's take a look at what goes on with the vascular supply inside the kidney. Inside the kidney, each renal artery will divide into a lobar artery and then a interlobar artery. So each lobar artery feeds a lobe of the kidney. Now, what's really interesting is that at the end, all those arteries actually create a series of arched arteries that sort of anastomose with each other and create an arcade. So here we actually have a picture of an architectural arcade, which, as you can see, is a walkway of arches. So that's kind of the structure you want to have in your head when you think of an arcuate artery. So arcuate artery just means it's an arcade artery, or we sometimes in English call them the renal arcades. Now notice that the renal veins have a sort of parallel structure to this, but in between those two are the glomeruli and the peritubular capillaries, which are the capillary structures that separate the renal arterioles from the renal venules. So through the arcades, which if you notice are sort of subcortical, they're not exactly at the cortex, but they're a little bit ways in, and as you can see, they help delineate the area between these grossly identifiable pyramids and sort of the subcortical tissue that lies underneath the capsule. Now, if you look at the gross section, you can actually see that area is where it's the reddest, because that's where the blood vessels are, that's where the capillaries are, and most importantly, that's where the glomeruli are. If you can actually look at the structure of those renal pyramids, you'll see that there's these striations that actually point towards the center of the kidney, sort of to the apex of each renal pyramid. Those striations are actually the loops of Henle in each nephron, and they're all stacking up and oriented towards the point of each renal pyramid. As we'll see soon, the filtrate that passes through the renal tubule will eventually go into the collecting duct, and those collecting ducts will all unify at the base of the renal pyramid and drip, drip, drip into those minor calyces. So now the word calyx in Latin means the husk of a bud. Think more like the husk of soybeans or the pod of a pea pod. So the calyx is really just that husk, that empty pod. And as you can see, that pod is where the urine is going to flow. So these minor calyces join up and become a major calyx, and all those major calyces actually join up and become the major hilum or root of the renal pelvis. Now, even though we still call it the renal pelvis in normal anatomy, I'm going to stop here just to actually talk to you a little bit about an etymological term, which is the Greek word pyelos. So pyelos means pelvis, which unsurprisingly refers here to the renal pelvis. So when we say pyelonephritis, we mean an inflammation of the renal pelvis, which means that the central mass of the kidney is infected, and that's different than a glomerulonephritis, which may or may not be infectious, and most often is just inflammatory. Now that we've taken a look at the gross structure of the kidney, its vascular supply, and its drainage, I want to talk to you a little bit about where that renal pelvis is heading, because that renal pelvis is going to narrow down and become the top of the ureter. So the ureters are just tubes, they actually peristalse, and they will bring the urine down from the renal pelvis down to the bladder. Renal pelvises, in Latin pelvis, will send one ureter down from each side, and both of the ureters will enter into the bladder, specifically in the back on a triangular section of it called the trigone, or at least at the edge of the trigone. Now, that bladder, if it's empty, is going to be really small and lie just behind the symphysis pubis. If it's really, really full, you can actually sometimes palpate it right over the symphysis pubis. Now, if you recall the striations on the renal pyramids, you can tell that some of the microscopic or histological features of the nephron are actually appreciable at the gross level in the kidney. So remember that dark red band that is not exactly subcapsular, but is definitely there sort of in the boundary area between the cortex and the medulla? That red area is where the glomeruli live. And as you can tell from this diagram, there are actually two types of nephrons. For both types of nephrons, the glomeruli live right at that corticomedullary junction. As we'll see later, it's going to be those short-loop nephrons that live mostly in the cortex that are actually going to be the nephrons which have access to the cortical collecting duct as opposed to the medullary collecting duct that you would expect from the longer loop nephrons. So the difference functionally that this structural difference will entail is that whatever it is the loop is doing, the longer looped medullary nephrons will actually do more of that requires the loop's function, and the shorter looped cortical nephrons will do less of the loop function. So, as we'll see later, those shorter loop nephrons that live mostly in the cortex are going to have more of the cortical structures. They're going to have more proximal convoluted tubule, more distal convoluted tubule, and more cortical collecting duct, which means that their job is going to be more about resorption and fine-tuning the ion and pH balance of the blood, whereas the longer looped medullary nephrons are going to have more of the loop of Henle's function, which is to, as we'll see, concentrate the medullary interstitium so that it allows the resorption of free water. Looking forward to one of the most heavily tested areas of normal kidney function, the endocrine control over renal function, what we can basically kind of say is that those cortical nephrons are going to be under the aegis of aldosterone primarily, and the longer looped medullary nephrons are going to be under the aegis of ADH. So I'm going to produce a video later about sort of internal and external spaces in the body and how we can define that, which is really useful for both answering endocrine and exocrine questions and also for embryology. Keep an eye out for that video because I really hope it'll be informative. So as you can see, the bottoms of the collecting duct sort of just exit from the bottom apical point of the medullary pyramids, and from that point, the urine will just drip, drip, drip into the hollow space of the pelvis. Once the urine leaves the pelvis, it's carried down from the kidney and out of the kidney by the ureter. The urine will stay stored in the bladder until it's convenient, safe, and polite to void under normal circumstances, as long as the person is continent. From the bladder, the urine will actually exit the body via a tube called the urethra. In women, the urethra is quite short and exits into the vulva. In men, the urethra is a lot longer, actually about 15 centimeters or more, because it goes from the base of the penis all the way out to the meatus on the glands. Now, that extra length is actually what protects most males against UTIs. The source of most UTIs is the pudendum. Now, in men, because the most common bacteria that causes UTIs, E. coli, would have to climb the entire urethra without getting washed away like the itsy bitsy spider, just getting washed away by urine. UTIs in men are pretty abnormal. If you have bacteria in the urine in a man, it is always going to be considered abnormal. Whereas if you have asymptomatic bacteriuria in a woman, well, unless she's pregnant, it's actually not that abnormal and not problematic and not necessary to treat it. Now that we've talked about the outflow path for urine, I want to return back to the kidneys and talk about how it's actually generated. In order to understand how the urine is made and the terminology involved in that process, we have to actually define some directional transport terms, both into the tubule, and thus into the urine, as well as outside of the body. Even though this video won't go into the details of topological divisions of the cells in the body, I just want you guys to understand that the inside of the nephron tubule is technically continuous with a space that is outside of the body. Because remember, whatever goes into the nephron tubule is going to go into the calyx, is going to go into the pelvis, down the ureters, out through the bladder and the urethra into the outside world. So, when the body puts anything into the urine or into the nephron tubule, it's actually technically pumping it outside of the body. The word lumen refers to the inner hollow space inside any tube. We could be talking about a blood vessel, the gut tube, the nephron tubule. Doesn't really matter. As long as you have a tube, the inner space is called the lumen. Now, the word lumen in Latin both refers to light and an opening, and as you can see with a little bit of imagination, it's not too hard to think about how an opening also means the same thing as light. In this specific meaning of the hollow space inside a tube, it probably just is better to think of it as the hollow opening. As we'll see in the rest of this playlist, the kidney is all about transport, so it really behooves us to actually talk about the directionality of various transport terms. Whenever we have a transport epithelium, that epithelium is a two-dimensional barrier between two three-dimensional spaces. That epithelium will have a side that faces the blood and a side that faces the outside world. So the reason we call it the basolateral side is because if you imagine every cell as kind of like a cube, well, there are 6 faces, right? And in terms of the directionality of transport, there's an inside face and an outside face. The inside face is the face that faces the bloodstream, which is the base. There are 4 lateral sides to any rectangular prismatic structure. And then, of course, the top of the cell is going to be the apical side. So the direction of secretion will always be from the blood, aka from inside the body, to whatever outer space there is. This definition of basolateral and apical is consistent through all the tissues in the body that have to do with transport. And there is no exception in the kidney. Anything that gets pumped out by the urinary epithelial cells into the tubule will actually be destined to leave the body and thus will be excreted. And that's the word we use when we talk about the kidney as an excretory organ, because it's secreting stuff into the tubule that will eventually leave the body. Whenever the urinary epithelial cell absorbs something, it's going to pump from the lumen into the blood along the direction of the blue arrow, which is absorption. Now, in the kidney specifically, secretion is excretion, because anything that is pumped into the lumen of the urinary tubule is going to eventually make its way out with the urine unless it gets absorbed. And of course, secreting something in and reabsorbing it would kind of be a futile cycle, so unless that happens passively, the body will not have evolved to have done that. The reason it's called reabsorption and not just plain old absorption is just the fact that at some point, all the stuff that's in the tubule either got filtered into the tubule or pumped there. Here we have a picture I drew of the nephron. Functionally, we can divide the nephron into 2 parts. The first part filters out or squeezes out the liquid solution from the blood. That's the glomerular filtration apparatus. That's there to the left side of the vertical line. Everything to the right side of the vertical line is basically the tubule of the nephron. And what the tubule does is it takes that liquid that got squeezed out of the blood and it manipulates it chemically to remove all the stuff that we don't want to pee out and to put in all the stuff that we really, really want to get rid of. What really defines the glomerular capillary bed is the fact that it's different from most capillaries in the body. Unlike most capillaries, which exist between an arteriole on the upstream side and a venule on the downstream side, the glomerular capillaries exist between 2 arterioles, and that's going to be a huge factor in determining pharmacology, treatment, and pathophysiology. From the Latin word roots ad, which means to or towards, and ferens, which means carrying, we have the afferent arteriole, which is the adferent arteriole, or the carrying toward arteriole. We also have the efferent arteriole, coming from the Latin word roots ex, meaning out, and ferent, again, meaning carrying. That is the exferent or efferent, or carrying out arteriole. Let's go ahead and name the different parts of the 2 functional divisions of the nephron. In the glomerular tuft, we have the vascular structures of the afferent arteriole, the glomerular capillary tuft, and the efferent arteriole, and then we have the receptive cup of Bowman's capsule in purple. When it comes to the tubules, we have actually 4 parts that we care about. We have the proximal convoluted tubule, the distal convoluted tubule, and the reason the proximal convoluted tubule and the distal convoluted tubule are both convoluted tubules is to increase the surface area, which usually means increasing surface area for transport processes, specifically in this case, reabsorption. We then also have the loop of Henle. There's a thin part of the loop of Henle and a thick part of the loop of Henle. And the thick part of the loop of Henle is not actually thick in terms of its luminal diameter. It's thick in terms of its walls. So while the luminal diameter is effectively the same in the thin part of the loop and the thick part of the loop, it is the tubular diameter that is larger in the thick ascending limb than the thin ascending limb. And that's not because of a luminal difference. It's because of the increased height of the urinary epithelial cells that make up the wall of the tubule there. Why do those cells in the urinary epithelium of the thick ascending limb need to be so thick? As you can see, because of the way I drew it, the cells of the thick ascending limb are jam-packed with boatloads of mitochondria, which implies that they need tons of energy for transport processes. Now, the collecting duct is not just a passive duct that collects things. Its urinary epithelium is actively transporting things in different amounts in response to the level of hormonal influence, as we will see when we get to that section's function. So the reason that the convoluted tubules are convoluted is to increase their surface area for absorption. In fact, the proximal convoluted tubule takes it even one step further than the distal convoluted tubule, and even the cell membranes of the urinary epithelial cells in the proximal convoluted tubule are convoluted themselves. They're convoluted because they have microvilli, which are kind of like finger-like projections of cytoskeleton over which is draped cell membrane. And at a histological level, we can see that under high magnification as a brush border. If you look at this histological picture of the kidney, you can actually appreciate which ones are proximal convoluted tubules that you see in cross-sections as circles, because you can actually appreciate the thickness of the brush border. Now, there is some crud in the middle of the lumen of the kidney, and that's always there. Here's an interesting critical thinking question. Would you expect the proximal convoluted tubule and the distal convoluted tubule to have a lot of mitochondria in those epithelial cells? If you said yes and meant it, you've really been paying attention, because all that convolution, all that increase in surface area is to enable room for all these transport proteins. And some of those transport proteins are going to be pumps, because it's pretty unlikely that all of this stuff is going to go on without any energy input. So of course we would expect the proximal convoluted tubule and the distal convoluted tubule to also be heavily energy requiring tissues with a boatload of mitochondria in them as well. I'd like to take this moment to thank my biology teacher who I had before I went to college. I had her when I was a child in elementary school, and I had her again when I took AP biology. Thank you very much, Ms. M. One of the things she taught me is that structure and function are really two sides of the same coin. That every structure has a purpose, a function, and that function should be achieved by means of the structure of the biological tissue, whether we're talking at the cell level, at an organ level, or at the organismic level. So in honor of that, I'm going to take you through the jobs of each section of the tubule. The first part of the tubule is actually part of the filtration apparatus. That's the Bowman's capsule, whose whole job is to receive the filtrate from the blood, receive that liquid fraction that's going to be manipulated chemically and be turned into urine. The job of the proximal convoluted tubule is to reabsorb the good stuff and to secrete waste acids. Now, jumping forward to the distal convoluted tubule, the job of the DCT is to actually fine-tune the body's fluid status and pH balance. And the reason I jumped over the loop of Henle is because the loop of Henle works in concert with a collecting duct to deliver a 1-2 punch. In short, the job of the loop of Henle is to create a hyperconcentrated medullary interstitium that will set up the driving force that drives a water molecule down its concentration gradient out of the collecting duct into the medullary interstitium. And that means that the job of the collecting duct is to reabsorb free water to maintain blood osmolarity. Thank you for watching this video on the gross and nephron level anatomy of the kidney. If you want to see more about the functional aspects of the tubule that we've just talked about, watch the rest of the video playlist. Be sure to like, favorite, and subscribe. And as always, if you have a question or just want to say hello, drop a comment in the comment sections below. And hopefully that'll make it easier for me to keep on making videos like this.